Hello, my hustlers. So, today in our class, we will be discussing a very important topic of renal cell carcinoma. So, this is one of the topic which is very important for your examination. So, another thing to remind you is don't lose hope. So, keep your hopes high, keep your faith high, because nobody in this world can cover whole of the medicine. Because if you see, the medicine is a very vast subject. What you can do in this short span of time is to cover up your important already studied stuffs and some other important high yielding things which I have been teaching you through my videos. So if you see, renal cell carcinoma is divided into different types. So among them, if we discuss first the clear cell carcinoma, so it is the most common type of renal cell carcinoma. So due to important time of yours, we will focus only on important question. So most common type of renal cell carcinoma is clear cell carcinoma, which is mostly sporadic, which harbors loss of VHL gene. So another question is, VHL gene loss is associated with clear cell carcinoma type of renal cell carcinoma. So what happens is, in both sporadic and familial cases, there is loss of sequence on the chromosome 3 by either translocation or deletion, and this location contains VHL gene. That is why the VHL gene is lost or deleted in case of clear cell carcinoma. So these were some questions related to clear cell carcinoma. Another important thing is, it arises from proximal tubular epithelial cell, particularly of the cortex. And why it is called clear cell? Because it contains glycogen and lipid. These are well differentiated tumors of kidney. So these are well differentiated, occurring as solitary unilateral lesion, and often a pseudocapsule is formed around this tumor. So they have been asking these type of questions since long. What they can do is, now they can give you a picture of histology where you have to identify this clear cell carcinoma along with a clinical history. So we will go through their histology pictures also and how to differentiate them. But before that, you should know basic features about each of these. So moving to papillary carcinoma, it is characterized by papillary growth pattern, and here the most common cytogenetic abnormality is seen is trisomy of 7, 16 and 17q. So papillary CA is associated with trisomy of 7, 16 and 17q. Loss of 18 in sporadic form and trisomy 7 in familial form. So here, despite means it is different from clear cell where both were having the same thing, but here sporadic has loss of 18 while familiar has trisomy 7. And what happens here in trisomy 7, there is mutation of MET gene. So they will ask directly, the MET gene mutation or 7q is associated with, so you will answer papillary carcinoma. Okay, now from where they arise from DCT, and they are multifocal and bilateral rather than the clear cell which was unilateral solitary. This papillary is multifocal and bilateral. Why I am telling you this is because in clinical questions you have to differentiate with the features the patient gets. So they will say you that the CT scan shows a multifocal bilateral lesion, so you will mark then papillary rather than clear cell. Another specific feature of this is that papillary are hemorrhagic and cystic and are specifically associated with dialysis associated with cystic disease. So this is the most common type of RCC which is associated in patients with dialysis associated with cystic disease. So how you can remember this hemorrhagic with, you can correlate this hemorrhagic with dialysis. So anything related with blood, hemorrhage and dialysis. So papillary dialysis, composed of cuboidal and low columnar cells and As usual, samoma bodies may be present. So by now you must be knowing what are the different conditions where samoma bodies are seen. Now another important type is chromophobe renal cell carcinoma. Now why it is important? Because it is associated with best prognosis and represent very less, that is 5% of RCC. What other things you must know is they have a fine reticular pattern described as plant cell appearance of their cells, and they have a prominent cell membrane with eosinophilic cytoplasm with halo around the nucleus. Also, they have a multiple chromosome loss and extreme hypodiploidy. So this is another question, that is in chromophobe renal cell carcinoma, which has a best prognosis, has a hypodiploidy, extreme hypodiploidy and multiple chromosome loss. So these were some important points regarding this chromophobe. So multiple loss we were talking about. So there is loss of 1q, 1 chromosome, 2, 6, 10, 13. So you need not to remember all of them. You need to only remember is multiple chromosome loss, and here 1 and 2 have been already given in option, so you can just go through it. So it arises from intercalated cells of collecting duct and composed of eosinophilic cell with perinuclear halo. Now moving to another carcinoma, that is collecting duct or Bellini duct carcinoma. Now this is the rarest type of RCC and which has got a very aggressive course. So here they are composed of malignant cell with a prominent fibrotic stroma, typically in medullary location. So these arise from collective duct cell in the medulla, and they have is very aggressive course. So 3 points you need to remember about them is rarest RCC, very aggressive, and arise from collective duct cells in the medulla. Now there is something called medullary cell CA, which exclusively arise with the sickle cell trait. So you have to remember this, that sickle cell trait and medullary cells carcinoma are associated. Now we'll summarize this here. So this is the takeoff point you will take from this slide, is that the most common type of RCC is clear cell carcinoma. Most commonly associated with dialysis with cystic disease is papillary carcinoma. Exclusively associated with sickle cell trait is medullary cell carcinoma, and best prognosis is chromophobe carcinoma with multiple deletions. Now these were the theoretical aspect. You need to see the images or the histopathology also to fully able to answer these type of questions. Now if you see here, this is the thing you will see for your clear cell carcinoma. So another important question is, there is Fuhrman's nuclear grading for renal cell carcinoma, specifically clear cell carcinoma. Okay, so this is the picture for clear cell carcinoma. Okay, clear cell carcinoma will look sort of like this, with visible nuclei in the high power field. This is for papillary renal cell carcinoma. So you can differentiate, just have an image based memory. You will be able to answer them based upon the clinical features they are giving and the picture you are seeing. And this is a summary of all of them. Here you can see the clear cell carcinoma, here the papillary renal cell carcinoma, here the chromophobe big cells, and here the collecting duct carcinoma. So we'll conclude this mini micro video of high yielding stuff, and we'll continue with the another one. Thank you.